Hello, everyone. Thank you for joining us today in our second webinar of the series of webinars for NLAAD 2018. Before we go ahead, I just want to let you know that our lines have been muted so we don't have interference with background noise. In order for you to share your questions, we have a questions and answers part of the webinar at the end, so you can write your questions on the chat box function. And you also know this meeting is being recorded, so we will share this record after the meeting in our website through email. Today's webinar is 2018 International AIDS Conference, Implications for the Latino in the United States. My name is Luis Mares. I am the Director of Community Mobilization Programs at the Latino Commission on AIDS. And today's presenter is Dr. Vincent Juliano Ramos. He's a professor at the Silver School of Social Work in New York University and the director of the Center for Latino Adolescent and Family Health. In addition, he's a nurse practitioner with the Adolescent AIDS Program at the Children's Hospital at Montefiore. Dr. Dilamo Ramos is an expert on the role of Latino families in promoting adolescent health, with a special focus on preventing HIV and AIDS, sexually transmitted infections, and unplanned pregnancies. At Montefiore, Dr. Dilamo Ramos provides primary care to adolescents living with HIV, PrEP for high-risk youth, and screening and treatment of sexually transmitted diseases. So, Vincent, you can go ahead now.
So thank you so much, Luis. I just want to say thank you to everyone that is on the call for taking time from your busy schedules to actually join the conference. And I also would like to just take a moment to acknowledge the Latino Commission on AIDS and thank the Commission, and in particular you, Luis, for organizing this and sort of doing all the work to make this possibility for all of us today. So I'm going to share my experience with all of you from the International AIDS Conference, and I think part of how I'm going to frame my comments is really to think about what the conference meant from my perspective, but also the kinds of linkages that I was making to the implications of what was being discussed at the conference to the Latino community in the United States. Luis has mentioned that I am a professor at New York University and also a clinician working at the Adolescent AIDS Program at Montefiore Medical Center in the Bronx. Can we next slide, Luis? So there are four things that I'm hoping to accomplish. I'm first going to provide an overview from the conference on the state of the global HIV/AIDS epidemic, and so I'll be talking about a lot of the progress that's been made, but then also identifying some of the places where there is continued work. I'll highlight the United States, in particular what's happening in the Latino community as I go through the data on the global epidemic. In addition, I'm going to talk about HIV prevention and what I'm characterizing as an HIV prevention crisis. And again, I'll be focusing first globally, but then kind of zooming in on the U.S. and then ultimately the Latino community. I'll talk about some key populations and why we must continue to think about key populations, and there needs to be a paradigm change in terms of prioritizing key populations, and why there's not going to be an end to the HIV/AIDS epidemic if we're not thinking about key populations. And then lastly, where I hope everybody will really join in a rich conversation, is really talking about what all this means for Latinos, and really what I'm calling, what others have called, the invisible HIV/AIDS crisis among Latinos in the United States. And so if I'm successful, those 4 points will be clear. And at the end, I hope that some of you will feel free to come or call in, will call in and actually share your comments and your perspectives on some of what I've shared. Next slide. So the first thing I want to do is just share the state of the epidemic. And so for anyone that's interested, I think at the end we'll clarify with Luis, but I think that the slides will be available to all of you to download. And you can actually click on the link that I provide that actually comes from UNAIDS and the Miles to Go report. So a lot of what I'm going to be presenting comes directly from the Miles to Go report that was presented at the International AIDS Conference, and it could provide greater detail on some of the things I'm going to be sharing. Next slide. So the first thing is sort of the big picture of where we are in terms of people living with HIV across the globe. And so there's roughly 37 million people living across the globe with HIV. And one of the things that I think is really interesting is that only about 75% of people living with HIV across the globe actually know their status. If you think about sort of where we are in the global pandemic, we've actually made quite a bit of progress. And so you can see here that there are sort of numbers associated with where people with HIV/AIDS live. In the next slide, I'll show you where there's been sort of great progress made, and then also where there's been, some cause for concern. But in our own country, in the U.S., we've got about 1.1 million people living with HIV/AIDS. You can see the bulk of people living with HIV/AIDS are actually in sort of Eastern and Southern Africa, and so about 53% of all people living with HIV/AIDS are in that region. You can see it's roughly about 20 million individuals of the 37 million that are living with HIV worldwide. Next slide. So global incidence, these are new cases, and so you can see at the very top of the slide, there's roughly 2 million people per year that become newly infected. And so in 2017, it was 1.8 million, but that number has been pretty constant for a while. And so that's one thing I want to flag, that we have not necessarily stopped new infections. We still have new infections that occur at a significant rate. You can see that since 2010, there's been a decrease overall in HIV infections, but there's been an increase in some regions. And so the ones where there has been an increase, you can see the circles. And so Eastern Europe and Central Asia, you can see Middle East and North Africa. Those are two areas in particular where there's been increases. You can see there's been decreases in actually Asia and the Pacific, as well as Eastern and Southern Africa, significant decreases. In the U.S., we had roughly 38,000 or so new infections, and our epidemic in the U.S. has consistently sort of plateaued around that number for quite some time. And so, next slide, please. So in terms of treatment, the number of people who are receiving antiretroviral treatment actually has increased dramatically. And so if you look at 2015, 2016, 2017, you can see there's been a steady increase in the percent of people who are actually receiving antiretroviral treatment. The dotted line at the top, the red line, which is total people living with HIV, represents the gap between the people that are currently actually getting antiretroviral treatment. And again, I want to reinforce that there's been significant progress here, but there's still a significant number of people that are not on antiretroviral treatment. And so on the right-hand side of the slide, you see that there's sort of a circular figure. It says percentage of people diagnosed HIV positive that are actually getting antiretroviral treatment. So the vast majority of people who are diagnosed are actually, about 80% are getting antiretroviral treatment. There's still 20% of individuals who are diagnosed who are not getting it. I think more troublesome is the percentage of people living with HIV that are accessing ART, which includes people who are diagnosed and not diagnosed. And so if you think about the previous slide, I said that only 75% globally of people living with HIV know their status. And so this 40% that is not accessing antiretroviral includes the percentage of people who are unaware of their status, as well as people who are diagnosed but are not receiving antiretroviral treatment. The WHO, the NIH, the U.S. guidelines all recommend that antiretroviral treatment should begin immediately upon diagnosis. And so again, this represents globally a significant gap in our response, something that we should all be concerned about. Next slide. So in terms of reaching the 90-90-90 goals, so here you can see, as I mentioned previously, that roughly 1 in 4 people living with HIV across the globe are unaware of their status. And that's actually quite different than the U.S., where in the U.S. the vast majority of individuals who are HIV positive are aware of their status. But for the U.S., our sort of challenges on linking and retention and also helping people to maintain viral suppression. And this represents, in our own country, a significant sort of challenge in terms of reaching 90-90-90. I think across the entire world, you can see that the targets for viral suppression are not being met. And so Globally, we still have significant work in terms of testing. In the U.S., we've done very well with testing generally. I could make some comments that I'll hold on to for a little later, but about young people and some of the ways in which we haven't identified many young people living with HIV. But overwhelmingly, in the U.S., we know most of the people that are in fact infected are aware, but issues around linkage, retention, and then for everyone, U.S. and the rest of the globe, achieving and sustaining viral suppression is a challenge. Next slide. So this is something that I think rings true for the U.S. as well as the rest of the globe. And so you can see here that the dotted red line is really the estimate of the resources that would be required in order to reach the targets. And so the 2020 targets. And you can see that over time there's been increases generally in sort of monies that are available for HIV prevention and treatment. However, you can see that across all of these years from 2006 up to 2017, that we fall short of that dotted red line. And so truthfully, where the greatest need is in low and middle income countries, there's significant disparity in terms of what would be needed to reach the targets and the amount of funding that is being allocated. In our own country, in the United States, there's been a proposed sort of reduction from the Centers for Disease Control to reduce prevention and research funding by approximately $35 million in the request for fiscal year 2019 budget. And so this is something that we need to think about because we certainly have work to do. And a little bit later, I'll be talking about some of the challenge, particularly for Latinos in our own country, and why there's just not enough resources, whether it be the U.S. or also the broader sort of globe. Next slide. So I'm going to talk about the prevention crisis, and so this is my second point that I mentioned, and I'm going to talk about some of what I see as being lessons that I learned from the conference and then also my own sort of take on things. And so why don't we jump in, Luis? Next slide. So this is a very interesting figure that was presented, and this also was in the Miles to Go report, and it really highlights that we can't solely rely on treatment. We've made, globally significant progress in terms of helping people who need antiretroviral medication to access that. However, we still need comprehensive prevention. And if you think about what is being depicted in this figure, a terrific and wonderful thing is that deaths among people living with HIV has actually reduced. And so you can see the 2017 figure that it's sort of going down, the slope is reducing. You can see the number of people living with HIV is going up, and that is in part to the people doing better because of antiretroviral treatment, but also because of the 1.8 or roughly 2 million infections that we still have new infections per year. And then you can see here that the new infections have been going down, but they haven't gone down to the point where we would like them. And so they're sort of plateauing around the 2 million point. You can see for quite some time, if you look at the bottom axes, you can see that, from 2000 or so forward, that they've basically been in that sort of 2 to 2.5 million. And that while they've gone down, they certainly haven't gone down to, being sort of that there are very few new infections. We still have 2 million, roughly 2 million per year. Next slide. So all this to say that one of the big take-home messages that I took away from the conference is that while we have tremendous progress as far as biomedical prevention, both in terms of treatment, PrEP, and PEP, and I'll be talking about those in just a second, that we're not going to be able to end the HIV epidemic in our own country or across the globe with biomedical approaches alone, that we're really going to have to rely on some of the core basics that those of us that have been working in HIV/AIDS for a long time, historically have sort of worked in these areas. It's going to take all of these components to sort of, end the HIV/AIDS epidemic. And so comprehensive prevention services, they're not only necessary, but they're also effective. And so what I mean by that is that sort of the work on barrier methods, in particular condoms, male condoms, obviously folks having access to mental and behavioral health services, stigma reduction at the community level and really helping folks living with HIV or at risk of HIV sort of grapple with stigma and how to reduce stigma. the social determinants that, where there's disadvantage, where there are social determinants that are unfavorable for populations, that there's certainly more of a tendency to see risk in HIV infection, addressing legal and policy barriers. I'm going to come to this in a couple of slides. There was a very powerful talk about criminalisation laws in the United States I found very moving at the conference. And then also ensuring sexual and reproductive health services broadly, not just HIV, but around contraception as well as STI and the integration of prevention and treatment of sexually transmitted infections or STIs, and also contraception with HIV. And then obviously substance use services and harm reduction. And so all these things together are going to need to be part of the response in a really significant and meaningful way. One of the things, again, that I want to highlight that was very clear at the conference is that treatment alone is not going to help us to end the HIV/AIDS epidemic in our country, or for that matter, across the globe. Next slide. So a couple of things that were interesting. So this is me sort of cherry picking some of the findings that I thought were really terrific. So one of the things that I was fascinated by at the conference was the development and progress that is coming along in terms of long-acting antiretrovirals for both prevention and also treatment. And so there was interesting talks on injectables, on oral pills, in addition to obviously what we have, but oral pills that would potentially last longer in terms of the dosing. And so there were ranges, and I've provided a link here from AMFAR. I was able to track down a very nice sort of review that talks about the injectables, the oral pills, the implants, and the vaginal rings. And these long-acting agents, again, will be good potentially for prevention and treatment. And the time that, they'll be sort of able to work between dosing range from weeks to years. And so I think, pretty cool stuff. One of the things that was particularly exciting at the conference were the results of a study called Prevenir. And so Prevenir really was a study, mostly of MSM. You can see here there are roughly 1,500 MSM. And it looked at sort of daily dosing of PrEP, pre-exposure prophylaxis, the way that we currently prescribe PrEP, which is, one pill once a day for prevention of HIV, and comparing that in terms of new HIV infections relative to on-demand PrEP, which is 4 pills. It was 2 pills prior to an exposure and then 2 pills after. And so the first 2 pills taken together, so sort of a double dose, and then a third and fourth dose with single tablets after exposure. And so what's interesting about the Prevenir study is that there were no new infections among participants in either arm. And so the reason why I'm sharing this is not to suggest that we should change our dosing of PrEP. I think at this point in the U.S. we're still doing sort of approved regimen of daily dosing of PrEP, but to simply say that there's progress that's coming in terms of both prevention and treatment around the dosing and the different ways in which people will be able to think about accessing, whether it be oral pills and sort of on-demand PrEP versus daily PrEP, or other forms of delivery, whether it be an implant, an injectable, a vaginal ring, or any of the many things that will soon be available, hopefully in the not-too-distant future, that will help us to provide individuals living with HIV or at risk with more options. Next slide. So this was something that I thought was also interesting. And so this really looks at sort of where PrEP is available. You can see here that there are some estimates that roughly 350,000 individuals who initiated PrEP globally. But most of those individuals actually are in the United States. And so again, this notion that biomedical prevention alone isn't going to help us to end the HIV/AIDS epidemic. The truth is that most of the PrEP uptake is actually in the United States. And in a couple of slides, I'll share with you a little bit about what we know about PrEP uptake in the United States and sort of notions that where it's most needed, it isn't necessarily reaching the populations of greatest need. Next slide. So there was a lot of discussion about condoms. I think for many of us that have worked in HIV/AIDS for a long time, we started off at least I know I did, with sort of a lot of work around condom distribution, helping people to use condoms correctly, consistently, and then over time that evolved into kind of where we are today, which there's been sort of a shift to a heavier focus on biomedical prevention. And so I don't want to suggest that we shouldn't be using our biomedical tools. We should. But again, I want to highlight that comprehensive prevention still matters. And part of that is certainly condoms. And since the beginning of the HIV epidemic, I learned at the conference that condom promotion has averted an estimated 50 million new HIV infections. That was a really nice estimate and really provided a strong argument for why we still need to be working on helping folks to use condoms correctly and consistently. I've mentioned that our prevention focus has slightly shifted away from condom programming. I think we need to get back into condom programming. I know in the United States, if you look at condoms, for example, among youth in our country, the sort of reports of young people using condoms that last sex have steadily decreased. And so not only do we need to think about, the important role that condoms play globally, but in our own country, and then also the unmet need. And so another important point from the conference was that there would need to be, 27, 28 billion additional condoms available in order to meet the unmet global needs for individuals who could potentially benefit from using a barrier method when engaging in sex. Next slide. So stigma reduction. I think a lot of us that work in communities, and certainly I would imagine lots of folks on the call, really know the impact of stigma, particularly on sort of vulnerable populations and groups that have historically been marginalized or who felt like they haven't been fully embraced by health and social services. And so the conference was very, very strong and clear that stigma and discrimination are associated with poor adherence to antiretroviral treatment, and that one of the things that we need to be doing as part of our comprehensive prevention package is integrating stigma reduction interventions into our HIV prevention and treatment services. If we're not able to do that, then it's pretty clear that stigma actually has a negative impact on the global goals that we want to achieve. Next slide. There was a powerful talk, it was a plenary talk on HIV criminalisation in the United States, and there was a keynote speaker that spoke about his own experiences of living with HIV and having been put in jail for, what was sort of depicted as an intentional transmission of HIV, when in fact, based on what he shared, it wasn't intentional and there was no HIV transmission. But what was interesting about this, that the talk really highlighted that criminalization doesn't really reflect the current science, that we know that, people living with HIV that are undetectable, that it's not possible to transmit. People who are virally sustained and suppressed and then can sustain their viral suppression, U equals U. It's not possible to transmit. And so important here is that many of these laws, and there are 115 jurisdictions in 76 countries, including our own, the U.S., have laws that criminalize some sort of behavior in relation to HIV. And those behaviors can range from, maybe what some of us might think as being sort of more classical or more sort of anticipated sort of characterizations of people who might, however rare, intentionally try to transmit HIV, to things that are fairly benign, that there was no intent. It could be something like a scratch, coming into contact with someone. I mean, things that just don't really make sense in terms of the current state of the science. But these laws further stigmatize people living with HIV. They're negatively associated with folks seeking treatment and certainly prevention services. And I think there was a strong message from the keynote at the conference that this is an area in the U.S. that we need to work on. You can see here from the slide that there are 34 HIV-specific criminal laws and or sentence enhancements applicable to people living with HIV. So now this is looking at the United States. And if you follow this, and this is coming from the Center for HIV Law and Policy, you can really see that in our own country there's quite a bit of work that we need to do in order to, sort of align the policy with the science. Next slide. So I'm going to talk about prioritizing key populations, and again, some of what I took away from the conference. So next slide. So here's a sort of global snapshot, and then I'm going to come to the United States. And so globally, what you can see here is that there needs to be a focus on key populations. And so you can see that, again, sex workers, people who inject drugs, MSM, clients of sex workers, transgender women, that these populations all represent globally important segments of the HIV/AIDS epidemic. You can see in the United States, which for the purposes of this slide, which comes from the data that I'm reporting here, the U.S. is sort of part of Western and Central Europe and North America, that MSM are the largest segment. And so I'm going to go to the next slide, where I think I do a little bit more of a focus on the U.S. epidemic. So key populations in the U.S. And so you can see here that MSM represents, close to 70% of new diagnoses in 2016. I think the big take-home message is that MSM are disproportionately impacted by HIV/AIDS. We know that. And then one of the things that I think weighs heavily, at least in my own work, and that I often think about, is that a significant number of new HIV diagnoses are among individuals, under the age of 30. And so you can see here that 42% of those new diagnoses in 2016 in our own country were among young MSM. And so across the entire MSM community, above and below 30, certainly the sort of burden of HIV new diagnoses is heavily and disproportionately impacting MSM. But I want us to keep in mind that young MSM in particular represent sort of a group that's vulnerable and that often is invisible in terms of our response. Next slide. So one of the things that I found really interesting and that I appreciated greatly at the conference, there was a lot of sort of vocal, sort of statements that were terrific about the transgender community. And so I think one of the frustrations at the conference was that many individuals who themselves are transgender or who are transgender advocates really talked about why is there inadequate data that's being collected from sort of global organizations or from national organizations on HIV/AIDS among transgender individuals. And so you can see here from some work that I'm citing from CDC that, basically you can see HIV diagnoses between 2009 and 2014, roughly 2,351 transgender people received an HIV diagnosis. The vast majority, 84%, were transgender women, 15% were transgender men. About half of these individuals lived in the South. There's also some data that suggests that about 25% or somewhere between 22 and 28% of transgender women are living with HIV. But I think what I really want to highlight, and that is something that I've become increasingly sort of tuned into and very much want to share with everyone on the call, or reinforce for those of you that already know this, is that there just is an absence of really good data regarding transgender individuals. And I think that we have to sort of agree as a community, the country, that isn't acceptable. The social rejection, the stigma, the violence, the discrimination from healthcare providers, from social service providers, the invisible status. If you look at the slide, I put that in red. The invisible status, the difficulty accessing prevention, the lack of opportunities for employment, for housing, for education, for life chances, that these things contribute to the challenges that transgender individuals face. And I think the conference did a good job at actually highlighting that this continues to be a major area where we need to focus, and that it's just not acceptable that we don't have enough data and also concrete strategies for transgender communities. Next slide. So two other groups that were talked about that I think would be very interesting for folks on this call. So one were migrants or immigrants. And so again, there's a lot of sort of public narrative about sort of migration, about sort of stigma associated with migration. about undocumented individuals or individuals who reside in our country but who may not have sort of legal status. This idea that the current climate is very much sort of not supportive of people being able to access prevention and treatment, and that these barriers are actually not contributing to us ending the epidemic, but in fact exacerbating disparities and making it harder for people to seek the assistance that they need. And it could be that these things are actually real in terms of the actual sort of barriers, or they could be perceptions that people have, but nonetheless, those perceptions or those very real barriers are impacting immigrants in ways that are not helpful to their health and well-being, and that ultimately work against the U.S. and, for that matter, more globally, for us reaching our targets. I want to highlight for a couple of minutes just young people. I think that one of the things that was really powerful at the conference is that there was recognition that never before have there been as many young people as they currently are in the world today. And so the world has had the largest cohort of young people ever, and I think that what's also true is that young people are disproportionately impacted along the HIV/AIDS prevention and treatment continuum, both in our country and globally, and that often, like much of what I've been saying with other populations, much of that is invisible. And so on every single indicator, whether it be testing or linkage to care, retention, viral suppression, young people fare much worse than do with their adult counterparts. Young people face unique challenges given that they are developing. There are all sorts of legal restrictions, and then also there's stigma and the absence of youth-friendly services. These are all things that are very much critical to being able to engage young people. And in a couple of slides, I'm going to talk about our own country, and I'll provide some more comments about some of the unique challenges that young people are having in the United States. Next slide. So for the last part of my presentation, I'm going to focus on, well, what did I walk away from and how am I applying this to the Latino context here in the United States? And so this is now me integrating what I learned at the conference to talk about what I call the invisible HIV crisis among U.S. Latinos. And so I'm going to highlight a couple of things that I think are important to kind of share with folks on the call. Next slide. So the first thing is that you can see here that there's roughly 230,000 Latinos diagnosed and living with HIV in the United States. You can see from the map, the sort of darker areas the darkest sort of reddish areas are areas where there is higher concentration. But you can see there's an estimated 252,000 Latinos living with HIV. And I think what's striking is that every other group in our country, and this is something that I hope folks will take away from this call, if nothing else, every other group, every ethnic racial group, every other group in the U.S. experienced either stabilization or reduction in terms of new HIV diagnoses, except for Latinos. You can see here that overall there was, an 8% reduction in HIV incidence. There was, in our country, there was a 6% increase among Latinos. And in terms of diagnoses, you can see that there was an overall reduction of 5% and a 4% increase for Latinos. And so again, it's not to say that it isn't bad enough that we have increases in the Latino community, whether it be the estimates that are the first number and then also the diagnoses, but we had increases within the context of where there have been overall reductions. And so that is the part that is most troublesome, that other groups are experiencing progress while Latinos have actually gone in the opposite direction where things are getting worse for us. Next slide. What's important here is that between 2010 and 2015, the estimated HIV incidence among Latino, gay, and bisexual men increased by 22%. And so the numbers that I provided previously were overall, but now we're looking at vulnerable Latinos at greatest risk. And certainly one of the groups that jumps right out as having really dramatic increases in terms of new HIV infections are Latino, gay, and bisexual men. And so you can see below, the actual diagnoses also increased by 22% among 13 to 29-year-olds. And so above the 22% is all Latino, gay, bisexual men. These are estimates. But below, when you look at the actual new diagnoses, you see the same basic pattern, that there was a 22% increase in the 13 to 29-year sort of age group. Next slide. You can see here that 84% of the total increase in HIV diagnoses among Latino MSM are really concentrated geographically, and they're concentrated in 6 states in Puerto Rico. And so the areas that are in red, these are the areas that really account for the vast majority of the increase in HIV diagnoses. So Puerto Rico, Florida, New York, Illinois, Texas, Arizona, and California. These are areas that, are central to the HIV/AIDS epidemic among Latino populations. I want to actually present another important point, particularly for those of you that might not be in one of those 6 or 7 geographic areas, that will be coming up in the next slide. Next slide. So this is very, very interesting. This was discussed as well, and I think that what is here is really some work that's been coming from the Centers for Disease Control, and this looks at what's called the transmission clusters. So transmission clusters are sort of what are known as microepidemics. These are smaller epidemics where HIV is transmitting at a much faster rate than what one would expect if you sort of look at the patterns of normal transmission. There are 60 rapidly growing transmission clusters that have been identified in the data that are presented here. One of the things I want to point out is that where that sort of bluish color on the U.S. map is, those are the places where there's currently molecular surveillance. And so in the areas that are white, there isn't molecular surveillance. And so the data that I'm presenting is actually based on the areas where there currently is, the 27 molecular HIV surveillance jurisdictions, which is what the MHS represents on the slide. The clusters are located in 20 geographic locations throughout the U.S., and I think what's important here is that rather than focus on just the 7 geographic areas that I mentioned in my previous slide, these data suggest that it's actually more widespread. If you look at the map, it actually is showing throughout the U.S. The areas that don't have any data are areas where there's not molecular surveillance to date, although in the near future there'll be data from actually all jurisdictions or from the vast majority. So let's go to the next slide. So I mentioned the idea of high transmission rates or high transmission events. You can see that under normal circumstances, what we would expect, these little blue figures represent people living with HIV. You would expect that there for all those people on the left-hand side that are living with HIV, that the transmission rate would look sort of more like, what is depicted on the left side, that there would be, sort of not a very common thing for people to actually become infected with HIV, relatively speaking. On the other side, on the right-hand side, what you see is what we call a high transmission cluster, where among people living with HIV, there's transmission at rates that are much, much higher than what one would expect. And so one of the things that was striking about the CDC data was that transmission rates were, in some of the clusters, were up to 33 times the national average. And so what this meant was that if you were connected to a transmission cluster, if you were geographically in an area where there was a cluster and you would network either through sexual behavior or through, sort of substance abuse behavior, that in those clusters, the transmission events were actually much, much, much greater relative to what you would expect in areas where there are not high transmission clusters. Next slide. This is probably something also that I hope that folks on the call will sort of keep in mind. And so they looked at these transmission clusters, and the CDC tried to understand, well, who is actually in these clusters. And they actually were able to identify a couple of sort of demographic factors that distinguish who was in the clusters. And so I've highlighted 3 here: Latino, under 30 years of age, and also MSM. And you can see here that under 30 years of age, about 70% of the rapid growth clusters were under 30. and you can see that roughly 40% of the rapid growth clusters were Latino, and you can also see that 83% of the rapid growth clusters were MSM. And so the message here is that while there are 7 geographic locations in our country that account for more than 80% of the increases in HIV diagnoses, the truth is there are microepidemics that are going on across the country that are being characterized as being high transmission clusters. And when you think about who's in those clusters, overwhelmingly you have Latino, you have youth under the age of 30, and MSM. And so this is a way of saying that I think we can't just rely on aggregate data about how our city or how, our state is doing, but we need to think about sort of microepidemics and what's happening with key populations. And if those key populations are experiencing elevated rates of HIV transmission, and that's something I think increasingly will be important in our response. Next slide. So this is a slide that actually was not presented at the conference, but I wanted to share because it kind of maps onto some of the points that I've been making thus far that did come from the conference. And so some data that is cited here suggests there are roughly 145,000 PrEP users in the U.S. in 2017. There are some estimates that I heard from really terrific presentation at CROI from a scientist at CDC about an estimate of the numbers of people that are eligible for PrEP in the U.S. or that might benefit, that number being close to a little over 1 million. And so right now, there are estimates of roughly 145,000 PrEP users. The estimates of people in need are closer to 1 million. And what's interesting here is that if you think about the numbers of people that are currently using PrEP in our country, what this pie chart depicts is that 73% of sort of the total, of the individuals using PrEP are white. And if you look on the side, 10% are African American and 13% are Latino Hispanic of our current PrEP users. And so if you look about sort of on the right-hand side, further to the right, if you look at the numbers of new infections, well, you can see that, the white community does have new infections, but certainly not as great as the African American and also Latino, which is the sort of largest burden. And yet, in terms of PrEP uptake, represent sort of a much smaller segment. So this disparity is only going to exacerbate sort of new HIV infections among communities of color, Latinos and Blacks, because the truth is, while PrEP is something that should be offered to everyone at risk, certainly we're not reaching the people who are most at risk. And so we need to try to figure out how to get PrEP to, Latino communities, to Black communities, and to other communities that are disproportionately impacted in terms of their risk for HIV. Next slide. So here's our care continuum. And so, again, it's being compared to non-Latino whites, and in the red are Latinos. And so you can see here that overall, Latinos do fairly well, but there are some areas of concern. And so we still have roughly 20% of Latinos who are unaware of their status. So 83% are diagnosed in our country. You can see here that of that 83% that are diagnosed, that only about 60% actually are receiving care. And so there's a drop there, the link between being diagnosed and then being sort of in care. And then in terms of, once you're linked, only about half of those that are receiving care actually remain in care. And so that's a further drop. In the U.S., as I mentioned earlier, one of the big challenges is that middle place of being linked to care and retention in care. And that's really different than a lot of what was talked about at the conference, when there are still fundamental challenges globally in identifying people who are living with HIV. But in our country, the vast majority, with the exception of young people, the vast majority of people living with HIV actually have been identified, but we're having a harder time in terms of linkage and retention. If you look at the last two columns, you can see there that only about half of those that are retained in care are virally suppressed. And so our greatest work is really thinking about how do we identify the remaining Latinos that are unaware of their HIV status. How do we start thinking about identifying young people living with HIV? I'm not showing you these numbers, but I'll share with you on the call that roughly half of young people who are living with HIV in our country are unaware of their HIV status. And so they're much smaller overall. Population estimates are about 60,000 young people in our country are living with HIV, but about half of them don't know they have HIV. And so we have work to do with young people. But what we all have to work on is, once we have identified people living with HIV, how do we help them in the U.S. to be linked to care, to stay in care, and to have sustained viral suppression? We know Latinos experience significant barriers, and so some of those barriers are the lack of culturally appropriate services, the lack of sensitivity, and also sort of responsiveness to the unique aspects of what it means to be Latino. We know health insurance, instead of being underinsured or being completely uninsured, not having access to PrEP, and there are certainly geographic parts of our country. I think one that jumps right out is Puerto Rico and the limited availability of PrEP in Puerto Rico, but not just Puerto Rico. There are areas along the U.S.-Mexico border on the U.S. side where PrEP may be a challenge. There are many areas, even in urban areas, where you think PrEP would be easily available, but in fact it's actually not available, particularly if someone has no way of paying for it or is undocumented and fears they could access a service that could potentially lead to them having a negative outcome. And so I've just given an example of sort of legal and policy barriers. I can share another. It was just recently in 2018 when the FDA approved PrEP, for example, for youth. And so again, there are many young people across our country who may not have had access to PrEP, who were at risk because of legal and policy barriers. The lack of access to comprehensive prevention, again, with the paradigm shift in recent years to biomedical prevention and treatment, there's been a tendency to sort of give up on some of our basics. We need to get back to that. Comprehensive prevention, stigma reduction, issues around how to deal with social determinants, and obviously how to ensure that we're reaching key populations. Next slide. So I want to wrap up before we get into questions or comments with something that I thought was very interesting. The last thing that happened at the conference that I thought was pretty terrific was a really candid discussion of the upcoming 2020 conference. And so there was a lot of heated debate and a lot of difference of opinion in terms of whether or not the International AIDS Conference should actually come to the U.S. There were some sentiments that the U.S., because of our current policies and our current government, federal government, that it wasn't really a place that would be embracing or accepting of the diverse communities that need to be at the table for the International AIDS Conference. There was an alternative view that having the conference in the U.S. is an opportunity to actually raise awareness of the issues domestically in our own country. I would say that with the exception of the Mexico City conference some years back, that for the most part, in all the years that I've been going to the International AIDS Conference, and I usually attend all the conferences and have done so for many, many, many years, there hasn't really been a lot of focus on Latinos. And so what I would love to lead everyone with, and what I also hope that folks will remember, is that I believe that U.S. Latinos and Latinos broadly from across the globe need to be visible and need to be vocal at the upcoming 2020 conference. I think we need to sort of come together as providers, as community members, individuals living with HIV, as individuals who have family members, friends, folks who we love and care about living with HIV. We take advantage of the opportunity to have our agenda be clear, to submit abstracts, to present research, to be involved in advocacy in the global village, and just make clear that the Latino community in the U.S., it's the largest ethnic, racial, minority group in the U.S. with exponential growth that will continue to grow. We need to make sure that our voice is heard and that our needs, particularly given some of what I shared today about the epidemic and the increases in incidents, that our voice and our agenda is heard. So with that, Luis, I'm going to say thanks to everybody for listening to me. I hope it was interesting, and I'm happy to talk with anyone or to try to provide any answers if I can. Thank you.
Thank you, Vincent, very much for sharing all this important information that you heard at the International AIDS Conference in Amsterdam this year. So we open the floor for anybody who has any questions for Vincent. You can write it on the chat box, and I'll read it, Vincent. Anybody? Yes, Rodrigo. The presentation will be sent in a PDF version after this conference is ended. Anybody have a question for Vincent? Well, while people start thinking what to ask, I want to share that the NLAAD campaign is already rolling. You can go to our website, NLAAD.org, and you can register your NLAAD events at the registration tab on the main menu, and you can also request HIV test donations for your event. We will send you posters as well, so please go to the website and register your events and request HIV tests if you need them. Since there's no questions, just want to thank Vincent for an excellent presentation. Bar Major is asking, what was the news on drug users? If you have any information on that, Vincent.
So Luis, can you repeat that again? What was the news on what?
What was the news on people who's using drugs on HIV?
Oh, so there was definitely lots of, so thank you so much for asking that question. I think there was definitely sort of data, particularly about sort of the raging epidemic in parts of Central and Eastern Europe and people who use drugs, particularly sort of injection drug users. And so there was recognition that, again, another key population that hasn't been adequately addressed. I think in our own country, there was discussion about, I guess, what some would call an opioid epidemic. Certainly, I would argue that the opioid epidemic has been going on in communities of color and in inner cities long before what's happening now. But I think that certainly what's happening now has gotten the attention of the broader U.S., and I think that there's sort of concerns about the next generation of potential injectors, particularly young people, because of what's happening in sort of largely rural America, and for that matter, in sort of white America. I think we have some examples of outbreaks of HIV in Indiana and other places in our country that were directly tied to, sharing of syringes.
People is asking if I'm going to make the presentation available. Yes, I repeat, I will send the presentation in a PDF version as soon as we finish the meeting. Any other question for Vincent?
So, Luis, I guess I would just say while we're waiting for the question that if anybody wants to follow up with me, my email is vincent.ramos@nyu.edu, and I'm happy to have any feedback or anything that you want to share with me that I didn't cover. I would love to hear from anyone. Thank you.
Thank you. And also for people to know that the AIDS International Conference is huge, and you probably were not able to attend every meeting that happened.
No, I picked the things that I thought were sort of that stuck with me, and there were certainly many things going on that I couldn't take part in.
Yeah. No, thank you very much, Vincent, for sharing all this information. It was very, very interesting. There's a question. Yvette Gonzalez, HIV and STD Prevention Program of Puerto Rico. I appreciate your information. Thank you very much. Somebody's running for Puerto Rico and thanking you. Yvette Gonzalez.
Oh, thank you so much, Yvette Gonzalez. Hopefully that things are hopefully getting a little better, but please do, email me and let me know how things are.
Okay, well, since there's no more questions, we're going to end up here. Thank you again, Vincent, very much for all this information in your slides. And thank you, everybody, for attending this webinar today. Don't forget to join us again next week on the webinar about the impact of HIV in Puerto Rico that we're having at the same time. Thank you, everybody.
Thank you. Thank you, Luis, for all your work again. And thanks to the commission. Thank you so much, guys. Bye-bye.
Bye-bye.